countries are making. I had the good fortune to work in Singapore for a couple of years, and you talk about an efficient port system. They can get equipment and anything in and out of that country very, very quickly. When you think about our ports and whether or not we're ready to support the level of exports we could have as a country, that comes back to the idea of infrastructure. So we think about it in all of those different terms. For education, we've said a lot today, and I think we'll continue that theme about focusing on science, technology, engineering, and math. And that's really, really critical to us and the skills that we need to be able to compete. But it's also important, as I said, that not every kid is going to college, and that's okay. We have opportunities for those kids as well, but again, they need to have the wherewithal to have something to offer, and that's where communities and the board like we have today and what we're talking about today is really a great opportunity for us to focus on what's next for those students as well. And then the idea of training and continual development. We have something at Caterpillar called Caterpillar Production System. And the idea is that those people closest on the shop floor to what's going on have the best ideas of how to improve. But that requires that the talent that's on the shop floor has the ability to bring those ideas in a constructive way. And that's something that we want to make sure that we are continuing as employers to train and invest in people. Because just as we said at the beginning, as we were looking at some of the numbers, as you become your own CEO, you also have to know when your skills are becoming obsolete and when you have to go back to retrain. And that's something that's really important for us to get across. So coming ready to learn, coming ready to contribute, a really critical part of the employment and the opportunities that we have. So my message today, just to wind up, is that there is opportunity, that those opportunities rely on a commitment and an investment, and that for all of us, whether you're an educator or an employer or community leader, that we need to take advantage of all these opportunities to invest in our workforce and to really make them capable of competing. Because at the end of the day, that's really what business is making the decisions on, is our ability to compete. And we think we can, right here from Central Illinois. Thanks.
Thank you, Kelly. Our next presenter is Dr. Sarah Rush. Dr. Rush is the Regional Dean for the University of Illinois College of Medicine here in Peoria. She is also a board-certified physician in internal medicine. Dr. Rush has been recognized as an educator and mentor of young physicians, an academic leader, and a skilled clinician. And I will also note that she has recently received the University of Illinois Woman of the Year Award, which includes all the University of Illinois campuses. Dr. Rush has been responsible for expanding the breadth and depth of medical education in our region, such as simulation training, research and health outcomes in cancer biology, and residency education. Dr. Rush.
Just going to see if my slides are on here, or you're going to do them from, you're going to do them? Let's see. All right. Not there. Okay. I'm going to move forward a little bit so I can see them myself. What I wanted to talk about is a little bit different perspective. If we could go to the next slide. Why are we talking about healthcare? Healthcare is more of a local entity. You know, we don't ship our patients generally to Singapore or wherever else. We don't worry about whether they fit on the freight liners or go through the ports. But healthcare is critically important to our community because if you look at the slide, you'll see that it is a huge part of our healthcare economy. So the economy of Peoria, the healthcare delivery system forms almost as big a piece of that as Caterpillar manufacturing does when you take that together. Moreover, each of us, whether we like it or not, is likely to be the beneficiary of our healthcare system. So having a well-functioning and well-performing healthcare system is important not only economically or for workforce development, but on a very deep and personal level of what you will receive as a healthcare provider. Next slide. I want to talk about healthcare looking at all the different factors. So when you look at healthcare, what's going to affect healthcare demand? Well, the first thing I'm going to talk about is aging, then patients living with chronic illness, the treatment options, patient expectations, and then local regional factors. If I could have the next slide, please. So this is the number of individuals in our communities who are going to be over age 65. So it was 3.1 million in 1900. It's going to be 72 million people over age 65 by 2030. So huge aging of our population over time. The second thing that's happening that's important to that is that the relative number of young people for each of the older people is smaller. All right, so that each of those older people have fewer working individuals who are going to be supporting them. Next slide. And even the old are getting older. You used to say that being 65 was old, and as I get closer to 65, I find that less appealing. But now we've divided 65-year-olds into three categories. There's the young old, which is the 65 to 75, the old 75 to 85, and then the very old, which are over 85. So not only do we have more individuals who are over age 65, but we have about 17 times as many that are over 75 and 46 times as many over 85. Okay? So older individuals consume more health care. They need more home health assistance. They're more likely to end up in nursing homes. They take more medicine. And what does that mean? You need more doctors, you need more nurses, you need more techs, you need more pharmacists, you need more respiratory therapists. All right, next slide. So this is the average healthcare consumption by age group that we just talked about. The young old, 65 to 74 at the bottom. All right, the old, 75 to 84, and then the 85 and older. So this is healthcare costs, which are tied to consumption. I'm not going to talk healthcare economy, just workforce. Of those ages. So not only do we have more that are older, we have more that are very old. We're going to need a lot of health care. Next slide. And even the young aren't healthy. You know, you would think that with all that we know about prevention, non-smoking, being thin, exercising, good diet, low cholesterol, that baby boomers would be healthy. But the fact is that in general, baby boomers, and I am one, are more obese, more sedentary, have more chronic conditions at a younger age, even though they are also more educated about their health. So knowing something doesn't necessarily change your behavior. And as a result, we're predicting increases in the number of ambulatory visits by about 30%. So next slide. So staying with demand, so then we have more patients living with chronic illnesses. Remember, each chronic illness needs more doctor visits, more meds, more et cetera. And so these are the chronic conditions, again, looking at those 65 and over. So heart disease, hypertension, which is high blood pressure. Over half of them will have high blood pressure. Stroke, asthma, bronchitis, emphysema, any cancer. Diabetes, we're seeing a huge upsurge in diabetes associated with the obesity epidemic, and arthritis. All right, so many of the people live longer and live longer with chronic diseases, thus increasing demand. Next slide. There's more available treatment options. So when you go into the number of drugs that there were when I started my career was much smaller. Now we've invented new diseases, new treatments, new options. And so there are things that we can cure. People that survive their heart attack because of interventions save money for the heart attack, but then they live to get their cancer. And then we might treat them and cure their cancer, but then they live to get their stroke, okay? And so every time that you save a life so people can live longer, they are actually sustained for more health care costs and more services. And then patient expectations. When I again began my career, and I hate to say this, we didn't have CT scans, okay? And so if you came in with a headache and you wanted your headache evaluated, you needed an arteriogram, which was dangerous, painful, uncomfortable, and so people didn't want to do that unless you really thought they had a brain tumor. Now you come in for a headache, the patient says, well, shouldn't I get a CT scan? You had a CT scan. Well, how about an MRI? All right? And so patient expectations are so high that they insult, not only do doctors trigger the healthcare, patients' expectations trigger healthcare. So we all say when we start that, doctors spend too much, they do too many unnecessary tests, but as soon as you walk into the emergency room, almost every patient wants everything triggered on their behalf, okay? So when you're talking populations, that's one thing. When you're the doctor taking care of an individual, everybody wants everything done and triggered generally for themselves. And so that drives it. And finally, for us locally, we're a healthcare economy. Our hospitals admit somewhere between a quarter and a third of their patients from outside the Tri-County area. This is good for us economically. It brings in patients, it brings in revenues, our families stay in our hotels, they stop at our pharmacies. And so as we grow that regional enterprise, the demand for healthcare services won't depend just on our local population, but really on our regional referral business. So overall, markedly increasing demand for healthcare services, not only in Peoria, but really across the entire country. The regional growth, particularly in Peoria. Next slide. So what's happening to meet all that demand? Well, there's actually inadequate numbers, and I'm not just talking physicians. Of course, that's my background. I do medical education. But nurses, respiratory therapy, occupational therapy, pharmacy, home health care aides. There's a shortage of healthcare workers. On top of an absolute shortage, there's a poor distribution. Many of you know that there's many fewer people choosing primary care. Roughly 2% of all graduating internists, that's general internists, are actually entering primary care at this point in time. The rest are going into subspecialties or into hospitalist work. Family medicine has had a marked decline in terms of the number of people applying for their positions. And then there's the difference between rural, okay? Rural communities have a very profound shortage. Urban, especially inner city urban, very profound shortage. Care for the poor, difficult to obtain. And then there's the whole issue of shifts. Okay? Unlike other paths, we expect our hospitals to operate 24/7. And under DRGs, where you get paid for a certain number of days, you need to deliver all your services. It's not like, Friday we can shut down and reopen on Monday. We have to deliver those services consistently over time. To do that, what kind of a workforce do you need? A workforce that's going to be there 24/7, days, nights, evenings, weekends, holidays, okay? And so this is a major challenge. People will come into the hospital to work. They might get their first job at night shift. As soon as there's an opening on day shift, where are they going to go? Day shift. But then day shift has to work weekends, so as soon as there's an opening in an office that's 9 to 5, or a nursing home that's 9 to 5, or a pharmacy or an insurance company for review, 9 to 5, where do you think they're going to go? 9 to 5. I don't blame them. All of us would like to work that. Changing work habits. We've heard a lot about how important it is to be an enthusiastic, aggressive worker, but the population ideas have shifted over time. What we admired when I was a resident was the person who worked 90-hour, 100-hour, 120 hours. That's not the model that our physicians choose anymore, and I understand that work-life balance is an important attribute. But as a result, when you're looking to replace a physician, we figure that a new hire is only going to be able to do about 2/3 of the work as a retiring physician, because their lifestyle that they want to live is going to be different. And that's true with many, I think, people across the board. And then increasing regulation and documentation. Every time there's a new rule or a new law, some healthcare worker is putting a new piece of paper someplace in their computer, in a checklist, in something. Implementing medical records causes about a 20% drop in productivity of physicians in the beginning. And if they're lucky, they catch back up to 0. Many ambulatory offices still tell us that takes them longer to do that. Every nurse that's answering the phone and recording all the pre-existing conditions is one less person in the workforce. And so increasing regulation and documentation are decreasing our workforce.